everyone. Tom again, and welcome back. I'm glad you're here for our 7th Discovery module from VisiQuest on age-related macular degeneration. In module number 6, we learned about management of common eye conditions like cataract and glaucoma that need to be considered when treating AMD. Again, some of the standard therapies for wet AMD may significantly impact coexistent conditions in parts of the eye other than the retina. Now, in keeping with our goal of taking care of the whole person, I'd like to navigate you on a careful look at the role of low vision assessment and some of the currently available aids for patients with AMD.
So, John, you've been in the trenches a few years. Looking back at your formal optometric education, how has our understanding of this disease, AMD, changed?
Dr. Joe, 35 years ago when I graduated, it was just a matter of identifying the disease when it came through the door and then counseling the patient and holding their hand while it went downhill. Now, we've gone through several generations of treatment for macular degeneration, which has gotten better and better. And so we've gone from a situation where we deal with depression to where we deal with hope.
Dr. Metzger, a big interest of mine is recognizing the importance of caregivers. They're very important, and I think they're often overlooked and excluded from the care process. Give us some pearls, if you would, that you've developed over several years of clinical practice. How do you involve caregivers?
The caregiver is extremely important for a number of reasons. One being encouragement, two being implementation of what we ask the patient to do and kind of overseeing that.
So, John, one of my pain points is when do I call a low vision subspecialist? When do I involve somebody with your expertise when we're looking specifically at a case of AMD?
Well, there are some times when the referring optometrist, who's not a specialist, can help out and is comfortable in doing that because of their experience or their interests. But then there often comes times when even they are not comfortable with dealing with the patient's needs. And I always look at the patient. If they're 20 happy with their vision, and I don't know what the second number is, it replaces happy, you know, it may be a person where you and I would be struggling and depressed and can't do what we need to do, but they're happy as a clam. And that patient doesn't need care. But you may have a 20, 40 patient, which we all would think, well, that's pretty good vision, who's just having a terrible time. And so we look at the patient's ability level and comfort level and the doctor's ability level and comfort level. And when a patient is struggling and can't get the things done they want to do, then it's time to refer to the low vision optometrist.
So, John, I'd like to share a case with you at this point. This is a color fundus photo of an 80-year-old lady's left eye. On exam, she has very mild early cataract, but she complains of difficulty mainly with reading, and especially transferring from one line down to the next. Give us your thoughts.
From the position of the loss of retina in the upper part there, we can tell that she has a visual field problem in the lower part of her vision. And so that's why it's hard for her to get from one line to the other, because her peripheral vision doesn't tell where that other is. And so if we've got a stable situation here, as you mentioned, and we've got that visual field loss, this is a candidate probably for some training in locating, fixating, eccentric viewing, perhaps. If we have a relatively stable patient, we can go ahead and probably counsel and prescribe some aids to help her out, because if it's stable, she's going to be able to use them for a while.
Dr. Metzger, how about one more case?
Good.
This is a 72-year-old patient. It's a color fundus photo of her right eye. Now, as you work through your busy clinic day, you meet new patients, new referrals to your practice, and I'm sure you start with a good, comprehensive, full eye exam. And there's a good reason. There's been a little delay between referral and when the patient meets you in your office. AMD is not a static condition. It's a dynamic disease. Things can change. So I know that you want to make sure you're acting on very current, especially current anatomical information. So give us your thoughts on this case.
That patient's had an event and hemorrhaging in the retina. So they're in a state of flux. It would be hard to, now if that's the good eye, it would be hard to recommend something permanently for that eye. What we usually do with patients who we know are going to be changing, they're in transition, we will find an aid if we can to help them do what they need to do and lend it to them. Let them use it during the healing process and then come back and reevaluate, because once that gets improved, we don't know then what we want to do, and we don't want the patient to be stuck with something that they're not going to use any longer. And then, of course, if the patient had not seen you, for instance, when they walked in with that hemorrhage in the retina, I would, of course, call your office, get them the care that they need for you to follow up on that. And because I know that you have experience with techniques which will shift that blood away from the central vision and improve their vision, then we can do something else, again, perhaps from a low vision standpoint.
So there's often some back and forth depending on that particular patient's case for whatever's in their best interest.
Absolutely. It's a team approach, start to finish. And we need each other in this. We can't be clannish about it. It has to be a free flow of patient back and forth, and then the patient will have the maximum outcome.
John, we've talked in our modules here about typical retinal imaging. We have some great techniques. The big ones, of course, are fluorescein angiography and OCT scanning. Is there anything that you can share with us specific to your subspecialty?
Probably our piece of the puzzle is when we have a patient, we will do a very specific visual field test for the critical area in the eye. Now, most patients are familiar with visual field tests, which test, for glaucoma and the peripheral vision. But we test on a macular field test critical points, many of them right in the central part of the vision. And that way we can pick out good retina, poor retina, and we can teach a patient, teach them new habits and teach them how to use that good retina.
I've heard terms like, I believe, microperimetry.
Yes.
And that's what you're speaking to.
Yes, microperimetry.
And that's a very patient-friendly test.
Yes, it's fairly quick for the patient. There are no x-rays. There's no dye to shoot in the veins. And the interesting thing about the instrument is because most patients wonder they're not looking in the right place, it follows the eye. And so it's much easier on them.
So it has built-in eye tracking, basically.
That's correct.
Very nice. John, keeping it real, insurance is always a sporty topic in healthcare. Help us understand what you've seen over maybe the last 10 years in terms of trends. Where does insurance stand in their appreciation of low vision care?
Over the last 10 years, I think it's been pretty static. And the patients ask this all the time because it's important to them. And they need to know what's in store for them in that area. There are parts of the exam which typically Medicare, because we're talking about elderly patients, will pay for. They will pay for the basic exam. They will pay for the occupational therapy care. And but what they don't pay for are two important items. One is what we call refraction and determination of magnification. Now, the refraction is, we all think of that as which is better, one or two. It's when we get the eyeglass prescription. We get in focus. Of course, we all know with macular degeneration, being in focus is not the problem. It's the retina that's the problem. But we have to be in as good a focus as we can. Now, In low vision care, we do a refraction maybe a little bit differently. And then the determination of what lenses we can magnify with, which is different than the eyeglass prescription, all comes under that all-encompassing refraction definition.
Let me just throw a true or false question at you, if I may. It's just a vitamin. It can't hurt. True or false?
The answer is false. There are some supplements or vitamins which may actually be counterproductive. For instance, some vitamins do cause bleeding, and that would certainly in wet macular degeneration be counterproductive to what we're trying to establish. So it's a good idea to ask your retina doctor, ask your low vision optometrist before you might think of something that's outside the box.
Dr. Metzger, patients come in routinely with newspaper clippings that say there's this new retinal chip. There's a new implantable telescope, and they just assume that we have it and it's ready to go. That presents an awkward situation. They're full of hope based on the media, and it's not always so. What have you run into with that?
Well, you're certainly right about new developments. We have patients come in all the time and talk about these things. As far as the implantable telescope is concerned, most patients are not going to be able to avail themselves at this time with that because the studies are being done just in certain locations, which may be a long ways away. There are very stringent requirements. Personality type is a factor. There's a 12-week, 3-month training period involved, and so it really eliminates a lot of people. Right now, it's not on the practical level.
I don't know much about this. Residency training programs in ophthalmology barely touch on it, if at all. But I know that there's an important role for lens tinting.
You know, Dr. Joe, that's one of my favorite topics. I wish lens tinting were easier to predict, but it's not. But it's something we always do with every patient because we see some amazing turnarounds with lens tints. We see improvement in contrast. We see improvement in what a patient can do. We see improvements in their safety as far as like going up and down steps, stepping off curbs, things like that. We have, as I say, we've had amazing turnaround cases just with tints. Now, gosh, I wish we could say it worked that well for every patient, and it doesn't. But it's a very important part, just lens tinting, a very important part.
Okay, that's a great take-home point. I just don't know much about that. That's the value to me of a team. You're going to know things that really help a given patient. That individualized approach, not cookbooking. It's fantastic. And you look at bang for the buck, you know, some things that don't necessarily cost a lot. We've got very expensive chemotherapy drugs. We've got lens tinting. It's amazing what they can do, especially together.
That's right.
John, looking at the whole team, that's so important. Do you think that there's a strong role for a provider outside of the clinic setting? For instance, where are things in terms of in-home education, that type of thing?
You said a little while ago there's a difference between high-tech surgical approaches and a simple filter which would help people. Well, here's something else which has historically gone unnoticed, and that's the role of the therapist on the team. That therapist is vital to what we do. They teach the patient to carry through on what we've asked them to do. They set the home up for success. They help the patient organize the home. They'll do specific things to help that patient be safe in their home.
Well, that's very interesting, especially since we've learned that in a clinic setting, the information a patient retains may be as low as 10%, which is scary. It's scary. I think patients come to us. Obviously, there's a factor of fear especially when their vision is concerned. And then I think patients come with a preconceived attitude that they're not going to understand the language of what we do. And it's certainly understandable. It's a very common human condition. But if the retention of information is as low as 10%, what you're saying makes all the more sense.
If we're trying to get that patient to best outcomes, from A to B, best outcomes, and they're only retaining 10% of what we told them, we need a team approach here. Once they get home, they need that caregiver's input and help. They need the home therapist's help to get things organized and get things running and to implement. And then the therapists are professionals on their own level, and they will come up with things that you and I won't even think about.
Well, John, my training was lacking in a few areas, and one of them, looking back, clearly was our understanding of low vision aids. What are your go-to tools?
Well, we always start simple and then see what else we need to do. Because if the simple thing helps, it's easier to use and it's less expensive. So the first thing is eyeglasses. Do we need to change those? The second thing is just simple magnifiers, something you hold in your hand. A higher level might be actually would be a telescope that you can wear on a chain around your neck, hold it up and identify what you need to see across the room or across down the street better. Then we jump into a little higher, more individualized devices, and then we actually might build a telescope into the glasses. Then we're talking about more expense, but for some people, it's just the thing they need. And we don't look at an elderly little lady and think she won't like that. She can't use that. Sometimes they do wonderfully with these things. So we try to step up from there. We can use digital magnifiers. Lots of people have closed-circuit TV magnifiers in their homes, which they do an amazing number of activities with. And all along the way, that occupational therapist, is integral in showing them how to use it. Not just showing them how to use the device, but how to solve their problem with it, and giving them encouragement all along the way.
Let's look at a few of these specifically.
Now, here's a handheld magnifier, and the nice advantage of it is it's portable. You can slip it in your pocket if you want. You can hold it up high, hold it down low. It's easy to use. Probably a difficulty with it, though, would be if someone's a little shaky. And some people have a hard time finding the right focus distance. Now, to solve that, we'll go to the next picture. And this is what we call a stand magnifier. Now, when you set this magnifier on the reading material, it's already in focus. So you don't have to focus it, it just sets there. Now, you'll notice it's a little more bulky. It's a little harder to carry around, but it can be incredibly useful in just in reading and a lot of other things that you have to do every day. Here's a telescopic device which you can slip on your head like a pair of googly-looking glasses and watch TV with it, watch your grandkids at a production at the auditorium with it. You can see perhaps better the songs up on the board in church. It's very useful, and this particular model is rather inexpensive. You can have them custom made if you have a special prescription. That would be more expensive. A couple of down points might be expense. Sometimes people have postural problems from arthritis and such, and they can't get things lined up. And so every device has its strong points and its weak points. Now, this item is a CCTV, closed-circuit television. You put the reading material or whatever else you want to see, like a pill bottle, underneath the camera on the table, and then you watch the image up on top. The image can be magnified. You can get different contrast levels. You can get it in different colors, colored backgrounds. It can be very useful. People do everything from crossword puzzles to checkbooks to painting, needlework. besides general reading. Now, a drawback is if you're reading a book, you have to slide that thing back and forth. Sometimes physically that's difficult. Sometimes perceptually it's a little dizzying to see the print floating by on the screen. And, of course, it's a higher ticket item, so that might be a drawback. Now, this is a bioptic telescope. You can see as the patient looks through the lower part of the lens, they have their normal prescription in there. But when they want to see something down the way a little clearer, they dip their head for a few seconds, sight what they want to see, and then they can put their head back up and look normally with normal peripheral vision. These are more expensive, but they can help people do a lot of things they couldn't do before. You can be active, you don't have to hold something, you have your peripheral vision intact, and some people will even use them to drive with.
Dr. Metzger, when you mention the therapist's role on the team, you made an interesting comment, and that is that they'll think of things that the retinologist and the optometrist may not. Again, looking at the individual patient and not cookbooking care, tell us some more things that the occupational therapist may come up with as they work one-on-one with their patient.
They may determine just what that patient's strong points and weak points are as far as their abilities are concerned that haven't come up in the examination. So they may advise them about things like talking books, large print checkbooks. They may advise them about how to mark their appliances so they can fix their food safely. And one of the really valuable tasks that our occupational therapist does, they help them find sources, if they can, for devices which, if the patient can't pay for it, there are agencies around which can provide those things, maybe on sort of a permanent loan basis or maybe at reduced cost. There are some service clubs which will do that, and we have contacts with a lot of people so we can help people that didn't think they could afford something.
Dr. Metzger, this has been very, very good. I've learned a lot.
When we work like this as a team, we have better chance for success, long-lasting success, less expense to the patient. We help individualize the treatment that we give them, and for that reason, we have patients who are safer in their homes, more productive in their lives, enjoying their leisure time, and become a member of their family. We have had patients walk out the door, and the caregiver pulls us aside and said, before Mom came in here, she didn't have an outlook on life. She was ready to quit. And now you can see by the smile on her face that she has a new outlook on life. And I don't say that as a tearjerker. That happens. That happens more often than you think. And so with the team approach, people are not at the end of the line, ever.
So what we have learned together is that getting from A, diagnosis, to B, best outcomes, is really optimized by a team approach. A diagnosis of dry AMD can be followed by optometric evaluation without delay. Patients with wet AMD, however, should usually defer further optometric care until they are deemed stable to proceed with optical options. Your retinal doctor will anticipate this and advise accordingly. Low vision services are typically tailored to a given patient's situation, just as cookbook care should be avoided in retinal treatment. In our next discovery module, number 8, we'll consider a tremendously important element of care, the psychological implications of AMD. Remember that many have navigated from A to B before you, so there's no reason to go it alone. Involve your caretaker and focus on communication. Make sure to join us, and remember, keep a steady heading and stay the course.